Dr. McIver is an endocrinologist at the Moffitt Cancer Center in Tampa, Florida. I started life in Edinburgh in Scotland and trained there, and then moved over to the US in about 1995 and came to Mayo Clinic in Rochester, Minnesota to do a fellowship in endocrinology there. I developed a particular interest in thyroid cancer under the mentorship of my colleague Dr. Ian Hay, from whom I learned a great deal, and spent almost 20 years at Mayo Clinic altogether before moving 2.5 years ago now to Tampa, Florida to join Moffitt Cancer Center. Moffitt is the third largest of the NCI-designated comprehensive cancer centers in the country. Memorial Sloan Kettering and MD Anderson vie for largest and second largest, and we're number 3 behind that. And as a comprehensive cancer center, our goal is to provide comprehensive care for patients with cancer of all sorts, including thyroid cancer, and also to design and develop and run clinical trials in thyroid in cancer, but including thyroid cancer, so that we're offering state-of-the-art therapy now and developing the treatments of the future. We can only do that because our patients are willing to travel and come to see us. Obviously, any cancer center depends not just on its local community, but rather on patients traveling from all around the country, all around the world, to take part in clinical trials. And we were discussing in the previous session a little bit about anaplastic thyroid cancer and some of the challenges in developing clinical trials in anaplastic thyroid cancer, where the patient pool is very shallow across a broad geographic range. There's only a small number of those individuals who are diagnosed each year, and in order for them to get access to clinical trials, they often have to be willing and able to move to travel many hundreds of miles to one of the large cancer centers to receive that kind of care. But the same applies to other types of cancer as well, including the more common types of thyroid cancer, that if we're going to make advances, we have to be willing to do scientific studies, including clinical trials of this disease. And one of the barriers to clinical trials in thyroid cancer, actually, I think there are 3 of them. Number 1 is that the cancer is diagnosed and treated primarily by endocrinologists, and endocrinologists are not used to thinking about clinical trials and the kinds of fundamental approaches to designing new treatments that medical oncologists are very familiar with. And because thyroid cancer is in the domain of endocrinologists and medical oncologists don't really see patients with thyroid cancer, it's been a very slow process to get to the point of doing clinical trials in thyroid cancer. The second barrier is a financial barrier. There's very little money in the field of thyroid cancer research because the drug companies haven't felt it's an important field. And therefore money hasn't flowed into study of new treatments in thyroid cancer. And the biggest barrier of them all is the fact that thyroid cancer is a good cancer. Okay, has anybody in this room not heard the phrase, thyroid cancer is a good cancer? If this is a cancer, if I was going to choose a cancer, this is the cancer I would choose. And of course, that is silly. It's inappropriate. It's disrespectful of people who experience this cancer. And it's fundamentally wrong, because thyroid cancer is not a good cancer. There is no such thing in my book as a good cancer. Good cancer is an oxymoronic phrase, and it shouldn't be used. What people are trying to say, of course, is the prognosis is pretty good for the average person with thyroid cancer, and that is true. Average life expectancy for all comers with thyroid cancer is actually a normal life expectancy. That's the good news side of the story. But that silver lining hides the cloud of what we put people through as they battle that cancer and live with that cancer and have a life sentence of that cancer, which may not be a death sentence, but nonetheless is still a life sentence, and it deserves to have that respect. And it's my patients over the years who've really taught me that need for that respect, much more than any textbook ever has or any other interactions with colleagues ever have. The truth of the matter is that not all cancer is good cancer. Many cases of thyroid cancer are truly incurable, And there's immense courage demonstrated by patients who face this terrible disease day in and day out. And I've been influenced by some of those individuals, a few of whom I'd like to acknowledge and mention. Rebecca Lord was, until her early death, leader of ThyCa, and she taught me a great deal about making sure you don't let yourself be defined by your disease. She lived a remarkable life despite being doomed ultimately by her thyroid cancer, and I learned a great deal from her. I learned a great deal from another patient of mine, Jim Howard, who never attended ThyCa, was far too busy in his own life to worry about crazy things like thyroid cancer, but he convinced me ultimately that we needed something more than just surgery, radioactive iodine, and bland platitudes about it being a good cancer. And he finally died of his disease about 10 years after his diagnosis with Hürthle cell carcinoma. Gabrielle Manoretto, who taught me the true meaning of courage in adversity and facing your worst fears. Gabrielle was a remarkable woman in her 50s who was a psychologist, and she became a psychologist because of her own fears, I think, including claustrophobia. And one of the most terrible things that somebody with claustrophobia can ever suffer is suffocation. And that young woman faced essentially suffocation and ultimately the need for a tracheostomy. And she lived with that tracheostomy with incredible courage over a period of about 5 or 6 years before her final early demise from the disease. And then I should acknowledge James MacDonald, who was the first person with thyroid cancer I ever saw when I was a third-year medical student. And this young man, well, he was in his early 60s at the time, I believe, was admitted to the hospital where I had a rotation, and I watched his anaplastic thyroid cancer grow from one day to the next, and his survival in the hospital for about 10 days before his early demise, rupturing a carotid artery. It was a hideous death. And the idea that that could ever be called a good cancer just sticks in my craw. But I should acknowledge all of my patients, all of whom face an implacable enemy, and most of whom face that enemy with incredible courage, with optimism, with determination, and with a bravery that I find truly inspiring, and it's what gets me up in the morning and takes me to work because I love what I do. Of course, thyroid cancer management is easy. Right? And in the 1990s, this was the standard algorithm. We did surgery, total thyroidectomy became the standard of choice. We did a central compartment node dissection routinely. I wrote part of the guidelines from the 2009 version of those guidelines that said central compartment dissection was routine for patients with thyroid cancer. We did select lateral neck dissections depending on preoperative ultrasound imaging. It's depressing how often that part of the evaluation is missed preoperatively, even today. And then we followed it with radioactive iodine, either to ablate the remnant or to treat residual cancer, and then suppress the TSH with levothyroxine, and then surveil and monitor TSH, thyroglobulin, annual stimulated thyroglobulin, whole body iodine scan, and ultrasound scan. And this was the standard approach to thyroid cancer in the late 1990s and early 2000s, and it worked. And everybody could be happy and could celebrate and could say we're all, doing a great job. Oops, here we go. Surgery, radioactive iodine, suppress the TSH, monitor. You'll be just fine. No big deal. It's only thyroid cancer. So that concept is driven by these data. These are Mayo Clinic data, but they are similar to data derived from a number of different large retrospective reviews of outcomes with thyroid cancer. And what this demonstrates is that patients with stage 1 thyroid cancer in the white line at the top, these are young patients, no matter how extensive the disease is in the neck, or older patients with disease confined to the thyroid less than 2 centimeters. Older meaning greater than 45, which is kind of depressing when we think of old greater than 45. But nonetheless, that stage 1 disease, you can see there were 2 deaths in this group of 1,360 patients, which gives you a 99.8% or 99.7% long-term survival. In a true sense of the word, that's good, okay, in terms of outcome. Of course, it hides the battle you face in getting to that good outcome in terms of the surgery and the radiation therapy and the TSH suppression and the monitoring and the fact that we bankrupt people more with thyroid cancer than almost any other cancer because of the expense and the inconvenience and the disruption in your lives that thyroid cancer causes. But nonetheless, the silver lining to the cloud, you live forever. So thyroid cancer, stage 1, generally favorable outcomes. Wonderful. Stage 2 cancer, here, that includes people younger than 45 with distant metastatic spread. So people younger than 45 with metastatic disease to the lung, or older people with disease still contained in the thyroid but bigger than 2 centimeters, that red line, still pretty darn good survival, about a 97-98% long-term survival, only a 2 or 3% chance that you're going to die of that cancer. So, silver line into the cloud. Stage 3 cancer, in this case, node positive in the lateral neck with people over the age of 45, that stage 3 cancer, about a 20% mortality. Now it's starting to become a real cancer. Now it's starting to become the kind of thing that oncologists look at and say, oh, some people do die of thyroid cancer. Yeah. But the medical oncologists typically only pay attention when it's stage 4C disease, distant metastatic spread in older patients, where these ancient data demonstrate every single person with that disease dead within about 12 years. Okay, that's a real cancer. That is not a good cancer. That's a bad one. Okay? Now, again, these are historical data. They may not apply anymore today, but it does remind you the vast majority of patients have an excellent long-term outcome. 46-year-old man, neck nodule in his neck, noted about 6 months ago, wasn't able to get into an appointment with a surgeon for a fine needle biopsy for a period of several months. That's not uncommon. In Florida, the average time to get into the endocrinologist's office for a thyroid nodule is about between 2 and 3 months. So you sit there for quite a long time. This young man was a busy businessman. He was traveling all over the country doing his work, and so he allowed this to grumble on for a long period of time, about 6 months before he finally got in and got this thing looked at. By the time he got in there, the neck mass in his, I think, left side was causing mild compressive symptoms. He was beginning to feel it there when he swallowed. He could feel it as a pressure there, but there was no hoarseness and no real difficulty swallowing. He had typical middle-class disease nowadays. You know, we eat too much and we get too fat and we get hypertensive and diabetic and hyperlipidemic, but otherwise he was in good health. He was on a bit of blood pressure medicine, a bit of diabetic medication and an aspirin, but he was a non-smoker, drank in moderation, and the only abnormal finding was this large 5-centimeter right-sided anterior neck mass. He had an ultrasound scan done, and it revealed a large nodule in the thyroid gland. There was no suspicious lymphadenopathy seen. His thyroid was working normally. He had a biopsy done, and it was non-diagnostic. Okay? And that happens about 5% of the time with ultrasound-guided biopsy, but as many as 20% of the time with blind biopsy, where you don't use the ultrasound. You get a non-diagnostic, so-called hypocellular specimen, not enough cells to make a diagnosis. He was reassured it was probably, quotes, just a goiter. Don't worry about it too much, we'll get to it. He had a repeat biopsy, also non-diagnostic. Okay, that was another 3 months went by before he had the repeat biopsy. So now we're talking about 9 months to a year since his original presentation with this growing neck mass. And you can see that time is beginning to tick away here. It's a problem. So 6 months goes by before he finally gets his right thyroid taken out. Okay, so this is now about 15 months since he first noticed this nodule, like more than a year, and he got the right side of his thyroid taken out for what turned out to be a 6.3 centimeter Hürthle cell carcinoma exhibiting capsular and vascular invasion. And what we know about Hürthle cell cancer with vascular invasion in particular is that it carries a much less good prognosis than your typical papillary cancer. This is not your good cancer. This is one of the more aggressive variants. In addition, 4 lymph nodes were identified at the time of that surgery attached to the back of the thyroid gland to contain thyroid cancer. So he was a node positive. He's 46 years old. He's got node positive Hürthle cell cancer, large and vascularly invasive. His post-operative thyroglobulin was 447. Okay, what that tells us is that he's got more in that neck than just the cancer that was taken out. And lo and behold, an ultrasound scan revealed a 1.1 centimeter cystic mass just above the thyroid gland at that 3-month follow-up visit following his surgery. And so he was recommended to go through a completion thyroidectomy with a lymph node dissection. And again, that cystic mass turned out to contain Hürthle cell cancer as well. So not only did he have the cancer, he also had an incomplete surgery first time around. And a second time surgery is never going to be as good as the first time surgery. Okay? This is one of the unfortunate things about not making a diagnosis the first time around when you get a non-diagnostic cytology, that you sometimes go in and do something less than a cancer surgery. And then when it is cancer and you're going back in, you're facing a scarred neck, it makes it harder to get the treatment right. Once again, a lymph node was identified containing the disease. Post-operatively, his thyroglobulin had actually risen, if anything. Now it's 590, despite taking out the other thyroid lobe. Despite taking out stuff that contains cancer, his thyroglobulin has actually gone up, which has to be a worrying sign. So, I think quite correctly, he's treated with radioactive iodine. Radioactive iodine does work for Hürthle cell cancer to some extent, although an awful lot of Hürthle cell cancers don't concentrate the iodine. Nonetheless, it's worth a try. And he received a 50 millicurie dose, quite a small dose, in 2006 to ablate the thyroid remnant. And that was followed by a 150 millicurie therapeutic dose. So this was a 2-stage radioactive iodine treatment, following which his scan was reported to be negative in January of 2007. By March of 2007, after 2 surgeries and 2 rounds of radioactive iodine with a suppressed TSH, his thyroglobulin was 2,349. Okay? So that's telling us something. And it's telling us, I think, what we already knew. This cancer was out of his neck and into distant metastatic sites by the time it was really diagnosed. He'd gone 1.5 years with cancer growing in his neck, and at some point, either before or during that time, that cancer had spread. His post-therapy scan was negative, his thyroglobulin was positive. He has thyroglobulin-positive, scan-negative disease, which carries a much less good prognosis than other types of disease. And then you can look and see how quickly his thyroglobulin is rising. It went from 447 post-op, it was 500 and something post-op the second time around. It's now up to 2,349, 4,200, 7,500, all in the space of just under a year. So he has rapidly progressive disease. We think about medullary thyroid cancer and calcitonin doubling times, and the rapid doubling time for medullary cancer carries a worse prognosis. We can think about that same concept with differentiated thyroid cancer. And although the data is a little softer, if you look at the time it takes for the thyroglobulin to double, that's going to give you some indication of how rapidly this disease is progressing. And we think about doubling times, say to go from, 2,300 to about 5,000, that doubling time in his case is about 5 months. And we calculate the doubling time that way. And rapid doubling time, less than 6 months, carries a worse prognosis. Slow doubling times, greater than 2 years, a much better prognosis. But the question for him is, okay, where is the disease? He's got a thyroglobulin now in April of 2008, 7,500. Where is the disease? Well, you have to go looking for the disease. And what you can see here is you can look for it with CAT scan, and he's got lumps of cancer within his lungs. You can look for it with PET scan, and you can see some of these areas lighting up in the lungs. You can also see hints of disease that might be in the bone, and you can see some residue of cancer here in his neck as well, probably in lymph nodes of the neck. PET scans are very helpful in assessing distant spread of thyroid cancer of various types, especially the more aggressive, rapidly growing, poorly differentiated versions of thyroid cancer. They light up very nicely on PET scan, but they're also visible on CAT scan as well. All of this does provide us, though, with useful staging information, and Hürthle cell cancers do light up on PET scans. So he was told, of course, don't worry, it's only thyroid cancer. Right? You've heard that many times before. Thyroid cancer is a good cancer. No one ever dies of thyroid cancer. If I had to choose a cancer, this is the one I would choose. And anything the surgeon leaves behind, don't worry, it's going to be mopped up by the radioactive iodine. Anybody in the room who has not heard those statements? All of them, the full house? Yeah. Of course, these are all very silly statements, as I've alluded to already. If you look at the outcomes of the Hürthle cell thyroid cancer in the right curve here, you can see stage 1, 2, and 3 carry generally pretty favorable prognoses, but stage 4A and 4C, which is the situation he's facing with distant metastatic spread, you can see that the outcomes are much, much less favorable with more rapid progression and potential for disease to kill. What are our options for therapy in this situation? Well, we've got surgery, but that's only really useful for stuff in the neck or to palliate disease that has landed up elsewhere. We've got radioactive iodine, but he's not concentrating the iodine, so it's really hard to get any benefit from that. We've got external beam radiation therapy, but you can't target every spot of cancer when it's widely metastatic. And we've got chemotherapy, but at the time he was being seen, none of these options was available because we didn't have any systemic chemotherapy. This was in 2007. Clinical trials in thyroid cancer for chemotherapy were not even being done at that time. And when he came to see me for the first time in this situation and said, "What have you got to offer me?" I said, "Well, nothing. We don't have anything. All we can do is track and monitor this disease, keep your TSH suppressed, and watch and see what happens. And hope between now and the time this disease gets to a point where it's truly threatening you, that we have something new available for you." There's nothing we can do. And all we can do is palliate. Okay, palliate. It sounds like a swear word, doesn't it? Just palliate. You know, it's a disgusting word. So we palliated this guy. But I took the view that he's a young man, he's got everything to live for, he's a businessman, he's got a high quality of life, he's no symptoms referable to his thyroid cancer, he is a family man, he's got 3 kids in their early teens, he's got a wife, he's got a business to run, he flies around the country in his private jet from one place to another doing his business work. The least we can do is try and keep him healthy by taking a pretty aggressive approach to palliation. Let's not wait for him to develop symptoms and then try to fix them. Let's try and fix his symptoms before they happen by setting up a surveillance and monitoring program so we could identify the disease. Here's his 3 rounds of radioactive iodine that he received over time, and here in the graph is his thyroglobulin over time. And you can see that he had a rising thyroglobulin. We identified something in his 4th rib on the left side, up here somewhere, that was really tender and bothersome. When he breathed, he could feel it. So we actually chopped that thing out of his 4th rib. We knew it wasn't going to cure his cancer, but boy, did he feel good not having a lump there anymore. He was happy. And we chopped that little rib out. And look at what we got with a thyroglobulin drop. He was over the moon. He spent 6 months thinking that we were the greatest thing that ever walked the earth. He got another one, showed up in a 2nd rib on the other side, and we actually chopped that one out as well. And you can survive with holes in your ribs. It's really not a big deal. In fact, after his 2nd surgery, he said, "You know, you made me spend a week not at work the last time. No way I'm doing that this time." He discharged himself from the hospital one day after his rib resection and went back to work that day. Okay, a remarkable man. He landed up with a lump in his left adrenal gland, over here, behind here, and we sent the surgeon in laparoscopically to take out an 8-centimeter massive tumor from his left adrenal gland. He was happy about that because it was beginning to give him grief in his back, and he really wanted rid of that thing, so we did. And we got a nice satisfactory drop in his thyroglobulin. He landed up with a problem at his skull base, up right under here. We couldn't remove that surgically. It was just too complicated, and so we radiated that area for him. And we got a drop in his thyroglobulin after his radiation therapy to that area. And then he landed up with a couple of pelvic masses that we chopped out. If you add up all of the surgeries he had over the time of his disease, we counted 16 separate surgeries to remove chunks of thyroid cancer, 4 different radiation therapies for different parts of his body, basically spot welding. And through all of that process, which went on for years, this was a 5 to 7 year course of treatments, his quality of life remained superb. There was one time after one of these rib resections, he was so desperate to go home that he had his buddy get in the bed and pretend to be the patient. And he managed to discharge himself from the hospital because the resident came in, saw this guy looking perfectly healthy and well, and said he could go. And then the patient himself came out of the bathroom with his chest tube in and kind of walking on his walking frame, but managed to get out in the wheelchair and left us. There was some trouble caused by that. But over all of this, despite all of these drops in the thyroglobulin, you can see there's a persistent upward trend. Okay, how much did we really extend his life by doing this? I don't know. But we maintained a high quality of life. The one that got me most forcibly was that he was on vacation in the Bahamas. And he took his family in his private jet and went off to this island in the Bahamas. And he went off-roading. And of course, off-roading, you're bouncing around like this. And he came in the next time he came to the clinic. He said, the only problem I've got is kind of a stiff neck here. So we took a look at his stiff neck. And lo and behold, what did we find? A deposit of his cancer sitting here at the C2 vertebral body. That threatened to transect his spinal cord. And so, him just telling us about the neck and the fact we were doing this screening, we were able to stabilize that with some rods and stop him from getting the Christopher Reeve Superman transection of his spinal cord. I told him, really, off-roading probably is not your thing. Let's do something else instead, a little more peaceful. We've got to remember that follicular and Hürthle cell thyroid cancer, just like other thyroid cancers, can be metastatic and it can be fatal. But at the same time, it tends to kill you slowly. And it takes a long, long period of time. On the average, for Hürthle cell cancer, it's 4.5 years from the time you're diagnosed with your first distant metastatic spread until that disease kills you, on the average. And there are some people who live for a decade or more with distant metastatic spread. It's slow. It's progressive, it's threatening in the meantime, it can cause symptoms, and it's worth managing and treating those symptoms even when you can't treat the disease itself. So options for therapy: surgery, radioactive iodine, external beam radiation, chemotherapy. What we ultimately asked was, what about a clinical trial? And this was right in the early days when clinical trials were just being talked about in thyroid cancer, and he was the guy who convinced me that we needed something more. That really we at Mayo Clinic had a responsibility to our patients in this situation to really drive towards clinical trials in thyroid cancer. And we were certainly not the first out there, but I'm pleased to say that as a result of this man's forceful advocacy, Mayo became a leader in clinical trials for thyroid cancer, and out of that span my interest in clinical trials, which has led me ultimately down to Moffitt Cancer Center. And there have been a number of clinical trials since that time that have been published and that have led to now approved new drugs, the tyrosine kinase inhibitor therapies. This is just one such clinical trial published back in 2008. It was one of the first ones that was published of this drug, motesinib, in progressive thyroid cancer. There was another one that we were involved in doing, this drug not yet approved by the FDA, but might be one of the next ones to be approved, pazopanib. And you can see here in response to that agent, a rising thyroglobulin took a big drop as soon as the agent was introduced, and we saw a reduction in volume of the metastatic cancer deposits in the lung in this case. Thyroglobulin fell from 7,500 down to 764 in the space of just 3 months. A remarkable response to this tyrosine kinase inhibitor in a Hürthle cell cancer. And it works at least to stabilize disease or to shrink disease in about 2/3 of patients. And this drug, like all of the other tyrosine kinase inhibitors, seems to work to stabilize disease in 1/3, to shrink disease measurably in another 1/3, and it doesn't seem to have any action in the 1/3 of the 3/3. Okay, and that applies to pazopanib and motesinib and vandetanib and any other of the inib drugs that work in pretty much the same way. And what's very interesting, over time we've discovered if you're not responsive to drug A and you switch it to drug B, you still have about a 30% chance of stabilization and a 30% chance of disease volume reduction with drug B and drug C. And the question now is, should we be switching from one to the other, to the third, to the fourth, and then back to the first again and begin to cycle those drugs? We haven't really figured that out yet, but it's one of the strategies that we're beginning to pursue. Each of the agents demonstrates about a one-third partial response, a one-third stable disease, and then about a one-third nowadays rather than 50% failure rate. Crossover between different agents can give benefit to different patients, and as sole agents, none of them is going to cure the cancer. So where we really need to go in the future is not just to rely on these stabilizing agents, which buy you a bit of time, but which ultimately are palliative, but instead what can we add into those drugs, or what can we cycle with those drugs to actually start to kill the cancer. So we need ultimately combination therapy. There is no solid cancer that responds ultimately to single-agent chemotherapy. They all require multiple agents to be effective, and thyroid cancer will not be any different in that regard. Combretistatin in anaplastic thyroid cancer is a drug I talk about a lot. I think the company that developed this drug, Oxygen, did a remarkable job of driving a clinical trial in a disease where it was always said you could never do a clinical trial. There's not enough patients with anaplastic. You'll never get anybody to fund it. You'll never succeed in doing clinical trials. That was all said within the space of the last 10 years about all sorts of thyroid cancer. You can never get a clinical trial done in thyroid cancer. There just aren't enough patients and there's not enough money. And here we are 10 years later with a multitude of published studies and approved agents through the FDA, at least 4 approved drugs through the FDA. Combretistatin, not one of them in thyroid cancer yet, but you can see even in anaplastic thyroid cancer some hint that the disease has some chinks in its armor and that we can actually succeed in treating this disease and prolonging life. But not without cost. Every action has a reaction, every treatment has a side effect. No matter what we do, we cause problems. And the idea that it's just thyroid cancer and it's all good is complete nonsense, of course. This man with significant grade 3 skin toxicity after radiation therapy, you can see was devastatingly damaged by his treatment, and that's just the visible stuff on the outside, not to say nothing of his difficulty swallowing and talking in the aftermath of this. It takes huge courage to face that type of toxicity and carry on with the treatment. Chemo has side effects, and even the tyrosine kinase inhibitor chemos, which are taken orally, have side effects. Nausea, anorexia and weight loss, fatigue is a very prominent one, nail and skin changes, hair changes, infections in the nail folds and in the nail folds of the feet as well, and of course very prominent diarrhea for many patients with this drug. It's the limiting factor. So these drugs are not trivial, they're still real chemo and they cause real problems. And of course ultimately, they don't always have a chance to work. This is an anaplastic thyroid cancer presenting late with disease that's ready to break through the skin. It's going to be very, very hard to do any kind of a rescue therapy in that situation, no matter how good our chemotherapies might be. And so there is a tendency for us to say, it's hopeless, there's nothing we can do. Dr. Toft, Professor Toft, was my mentor in Edinburgh. He was the guy who first got me interested in thyroid cancer, and he was the guy who sent in Mr. MacDonald with his advanced progressive anaplastic thyroid cancer. And Dr. Toft gave me some advice early on when, in response to his question, what next, I said, there's nothing we can do. And he said, and I will quote, there's never nothing we can do. The most important thing that we need to do is to remember why we're here, to be a physician and a healer, to make our patients feel better. We can give him pain relief, and we can be honest with him and with his family. We can help him and them come to terms with this hideous disease, and we can help them to understand what he faces. We can educate them, support them, and guide them, because we're here to treat the patient, not the disease. And those were wise words indeed, and words that I've taken very seriously over the years. Because palliation is not a dirty word. Treating patients for their symptoms or to prevent those symptoms is one of the primary roles of medicine, even in this day and age. It used to be the only role we could play. It still is a major role. Realizing that cure is not possible does not mean that you're quitting the fight. And when the time comes, it's important for both the patient and the physician to recognize that more treatment isn't always better. And the biggest and most courageous step that any of us ever take, physician and patient alike, is the decision to know when to stop. Most importantly, thyroid cancer is not trivial, and it should never be trivialized. I appreciate your attention this afternoon, and really, again, I'm honored to be in front of you. Thank you.